So it's still unclear, though, what the role of acculturation may play in immigrant populations with SLE. A survey was devised by Illumina to assess levels of acculturation in their Texan Hispanic population. They assessed place of birth, upbringing, language preferences, type of neighborhood, social interactions, etc. What they found was that patients with lower levels of acculturation had less education and were less likely to have private insurance or social support, and yet they had less disease activity. And this is counterintuitive, given we'd figure that patients with less social support, less language skills, less access to care would actually have much more disease activity. And it was actually those that were most acculturated had higher disease activity. So genetic factors confer an increased risk for SLE, but the risk is not absolute. If it were absolute, the risk in monozygotic twins would be 100%, but it's actually between 24 and 58%. So other factors have to be investigated, particularly in severely affected U.S. populations such as African Americans and Hispanics. Unfortunately, there are factors such as poverty, decreased education, and decreased access to care that are inextricably linked to minority populations in the U.S. Finding other factors are important because U.S. minorities tend to carry such a high burden of disease. African Americans have higher rates of disease activity at presentation and as the disease progresses. They have higher rates of lupus nephritis. They also have higher rates of end-stage renal disease as well as chronic renal failure from said lupus nephritis. They're more likely to accrue disease damage as the disease progresses, and they respond less to treatment as compared to Caucasian patients. The same, for the most part, can be said of Hispanic patients in the U.S., where they have similarly high activity profiles when compared to African Americans. They also have higher disease activity at presentation and over the course of disease, and have higher rates of lupus nephritis when compared to Caucasians. They also have high rates of damage accrual as well. So I just want to take a minute to actually discuss the Illumina cohort. There have been many studies before, concurrently, and after Illumina that have looked at racial and ethnic disparities. However, Illumina was the first cohort to really be devised for the sole purpose of evaluating the disparities that exist in minority populations in lupus. So in 1994, the Lupus in Minorities Nature versus Nurture cohort was begun to help decipher the role that other environmental SES factors may play in lupus. So Illumina is a multi-ethnic, multi-center cohort. It's longitudinal. It's predominantly African American, Hispanics of Texan and Puerto Rican origin, as well as Caucasian. Hispanics from Texas are mostly of Mexican descent. The three centers include the University of Alabama at Birmingham, the University of Texas Health Science Center at Houston, and the University of Puerto Rico Medical Science Campus. This cohort has over 600 participants. All participants meet ACR criteria for the diagnosis of SLE, and all are at least 16 years of age. A lot has come out of the Illumina cohort with regards to socioeconomic status in this population. So Illumina and others have helped highlight how SES is associated with increased disease activity, rates of damage accrual, and mortality in these populations. So in 1998, Dr. Alarcón and her group published one of the first studies from Illumina evaluating SES and SLE disease activity. They found that disease activity as measured by the Systemic Lupus Activity Measure was higher for African Americans and for Hispanics. Race and ethnicity predicted higher disease activity in multivariate analysis. However, for African Americans, the lack of private health insurance was also associated with higher SLAM scores. So there may be some interplay with race as well as socioeconomic status and disease activity. Further studies have shown that increased disease activity, while also being associated with race and ethnicity, is also associated with less education, living in poverty, and lack of health insurance. There's been also some evidence for socioeconomic status influencing lupus damage accrual. So in 2001, Illumina investigated factors associated with damage accrual in their cohort. They found that disease damage as measured by the SLIC disease index, so the SDI, was associated with age, steroid use, the number of ACR criteria met, disease activity, and illness-related behaviors in the overall cohort. However, for African Americans, though, poverty was associated with higher rates of damage. And so again, we see some interplay with socioeconomic status and race. Later, Illumina repeated the analysis to account for disease activity in their cohort. And again, poverty was an independent predictor of disease damage along with age, Texan Hispanic ethnicity, the number of ACR criteria met, disease activity at the time of diagnosis, and steroid use. This was corroborated by the Carolina lupus cohort, where while being African American confers a higher risk for damage accrual, patients with lower incomes had higher total damage scores and higher rates of renal, cardiovascular, musculoskeletal, skin damage, and diabetes scores. There's also been evidence to show that SES, in fact, influences mortality rates in lupus. So several studies have found that poverty may be more important than race in predicting mortality in lupus patients. So the Hopkins lupus cohort has found that African American race is a predictor of mortality in bivariate analyses, but the effect actually disappears in multivariate analyses when adjusted for education and poverty. So when accounting for other factors, race actually isn't as important as education and poverty in the Hopkins lupus cohort. Again, we see the Carolina lupus cohort where socioeconomic status actually better explain mortality rates in African Americans than race itself. And in the Lumina cohort, poverty rather than race and ethnicity is an independent predictor of mortality. How can we address these disparities? One of the first things that we need to do is raising public and provider awareness of the racial and ethnic disparities in healthcare as a whole, as well as in lupus care itself. Number two, we need to provide an increasing number and capacity of providers in underserved communities. Number three, improving the quality of care, and that's important for primary care providers to understand the need for lupus patients to follow up regularly with rheumatologists, particularly if they're on severe immunosuppressive drugs, et cetera, and to monitor closely for any sequela that may confer a higher risk of mortality and disease damage in lupus patients. And also increasing the knowledge base on the causes and interventions that we can do to reduce health disparities in this population. So when addressing healthcare providers, it's important to, as this talk shows, to have evidence-based presentations to demonstrate the facts that disparities have been identified in lupus with regards to race and ethnicity, to integrate disparities research in the curriculum, not only for medical schools, but also for rheumatology fellows as they go on into their training. We also need to train faculty to help address these issues with regards to fellowship training. And then on a higher level, strategic planning in institutions and healthcare providers in their particular communities in order to help eliminate these disparities, as well as encouraging overall national advocacy and policy changes that address health disparities.